Systemic lupus erythematosus, while relatively uncommon in the population, is the most common rheumatologic condition that leads to hospitalization. However, with diffuse multisystem involvement, it may be difficult to recognize whether a manifestation is a result of the disease or the treatment. A 47-year-old male was transferred from outside facility after a 2-week history of scant hemoptysis, who subsequently developed acute respiratory failure secondary to diffuse alveolar hemorrhage, requiring intubation upon admission. Additionally, the patient was found to have acute renal failure requiring renal replacement therapy and ICU-level care. Initial differential diagnosis included antiglomerular basement membrane disease, ANCA-associated vasculitides, catastrophic antiphospholipid antibody syndrome, and systemic lupus erythematosus. He was found to have positive p-ANCA, ANA, and low C3 complement. Renal biopsy was significant for crescentic glomerulonephritis. Treatment was initiated with cyclophosphamide and high-dose corticosteroids for presumed lupus vasculitis. However, despite this, his AST and ALT numbers began to rise significantly 2 weeks into treatment. Initial liver imaging was only remarkable for fatty liver disease with minimal fibrosis. Initial read of his liver biopsy showed venous congestion suggested of cyclophosphamide toxicity, so he was transitioned to mycophenolate mofetil for management of his lupus. However, despite discontinuation, his LFTs continued to rise. After definitive read returned, the liver biopsy showed early nodular hyperplasia consistent with hepatic involvement of lupus. He was continued on conservative management of his liver injury with avoidance of hepatotoxic medications and mycophenolate with prednisone taper for treatment of his lupus. Prior to discharge, his LFTs began to trend downward as evidenced in figures A and B, continuing to confirm the diagnosis that liver injury was secondary to his lupus. Lupus is more common in women with a prevalence almost twice that of men. However, men have higher mortality within the first year. The most common systemic manifestations of lupus include constitutional symptoms, arthritis, mucocutaneous involvement, and renal involvement. Other systems commonly affected by complications of lupus include cardiac, such as myositis and pericarditis, pulmonary, such as pleuritis, neurologic involvement including stroke, seizure, and cognitive dysfunction, and hematologic complications including anemias and leukopenias. Pulmonary hemorrhage is a rare but life-threatening manifestation affecting less than 5% of lupus patients. Additionally, early nodular hyperplasia is rare in lupus, as lupus itself rarely causes elevated LFTs. So in addition to this patient being male, which may have made us less likely to consider lupus as the diagnosis, he had 2 rare manifestations of this disease. This case highlights the importance of recognizing the potential widespread effects of lupus and the atypical ways it can present in the hospitalized patient, as this is key for effective management of this critical illness.